A great pleasure to join you in this afternoon. So you asked me to talk about endoscopic third ventriculostomy. This is one of the most frequent endoscopic procedures. What we do, we have now in our database 535 cases of endoscopic third ventriculostomy, which we collect since 1993. It's not so much. We have not so much cases. We have a close collaboration with Cairo University, and we made a study about hydrocephalus over 1 year, and we had, I think, 25 cases, and Cairo had 800 cases. But nevertheless, ETV is a very simple procedure technically, but you have to take certain precautions to make it a safe procedure. And that's what I want to talk about. So what we use in our department is a Schroeder ventriculoscope. There are two different sizes. One is for ETV and pediatric cases. The bigger one is more for tumor resection, septostomies, arachnoid cyst, call it cyst resection. But the shape and the function is the same. And you look at the diameter, this is 3.6 millimeters, this is 6.5. You see here we have a large working channel which we use for colloid cyst, tumor resections, and similar procedures. And the small one we use for ETV, biopsy, and fenestrations. Each ventriculoscope has an endoscopic sheath and a trocar, which is introduced. And you see there's a lens marking that you don't know go inadvertently too deep. You can measure, dura 5 to 6 centimeter, you should hit the ventricles. When you don't hit it, it makes no sense to go to 9, 10, 11. That is a sign that the trajectory is not okay. So here again, little Lotta, 3.6 millimeter outer diameter, has a larger working channel, 1.2 rod lens, which gives a very good view. Although it's so small, gives a much better view than the fibroscopes, which were labeled previously. The working channel is 1.6, and we have small side channels for irrigation. And with the left hand, we guide the system. And with the right hand, you control just the depth of the instrument. When you see people, when they start, they try to move the forceps left and right, but it's not working because you have this rigid, large working channel. So with the left hand, you guide the direction, goes also the depth of the endoscope, and with the right hand, you just can open your instrument. Navigation can be easily adapted to the system. For ETV, we don't use it. We have always a discussion at the IFNE courses at Naples with Papicinelli. And most people say nowadays we always use navigation also for a standard ETV to make sure that you really have the ideal approach. As I said, I don't use it when I have wide ventricles. I just take it freehand. But if you have a strange trajectory or you have slit ventricles, then of course you need navigation to make it safe. This is our setup in our operating room. So what are the indications for an ETV? The indication is any occlusive hydrocephalus with obstruction behind the anterior third ventricle. So everything which is behind, which obstructs the CSF flow, can be in the dorsal third ventricle, pineal region, aqueduct, fourth ventricle, outlet of the fourth ventricle. This is a good indication. But it should be occlusive hydrocephalus. We had also some experience with non-occlusive hydrocephalus, communicating hydrocephalus, and this is not working very well in our experience. What is very important before you make the procedure, you should study the anatomy. And for that, you need a very good MR imaging. At least a CT scan should be available. What we want to see. At first, you want to see where is the position of the basilar. That's very important. Sometimes it's close to the clivus, sometimes it's more posteriorly located. You can also see it on a CT scan. That is what is very important. Then we want to see where is the obstruction. So typically you have here, can you see my mouse? Is it visible?
Yes.
So you see here there is an obstruction in the aqueduct, and you have the pre-stenotic dilation of the aqueduct, typical sign of occlusion. You have the bulging of the floor. you have bulging of the lamina terminalis. And these are all signs of obstruction, and then it's a good indication. We also have a flow-sensitive sequence. It's the inversion recovery turbospin echo sequence, where you see flow void as a black signal. You see there's no flow, so no black signal. That means there's some obstruction. Initially, we use the dynamic CNE MR imaging, but this is more time-consuming, takes more effort. So I think for clinical use, the standard inversion recovery turbospin echo is sufficient to evaluate the flow. And then it's very important, you should look at the foramina of Monroe. What is the size of these? When you see here a patient, there was done an ETV and an aqueductoplasty. I was an expert witness in this lawsuit, which resulted from the treatment. You see, there's not much bulging, so it's a little bit obstruction, but not too much. And then when you look to the foramen of Monroe, on this side, on the left, there's a very small, on the right side, it's almost absent. But nevertheless, the surgeon came from the right side with a really large ventriculoscope. It was the Wolf scope from Kemet. And you went, make an ETV, and then he tilted it to make an aqueductoplasty. And of course, when you do this and you have no foramen, you damage all these structures. And this is what unfortunately happened. You see the whole central gray is almost destroyed. There was a puncture to the pons, midbrain. You see the thalamus damage. And here, especially here, you see the whole midbrain is severely damaged. And the patient had an obesity of 120 kilo, has no day-right rhythm. It's really a disaster from a simple ETV. And this should not happen. We should look at the MR images before we start with the surgery to avoid such a catastrophic outcome. This is tetraventricular hydrocephalus. You see the obstruction is here, Magendie and Luschke. Large fourth ventricle, large aqueduct, everything large, and we just made a simple ETV and the whole problem was solved. So, about the technique, where should we enter? We enter towards a precoronal borehole. We go through the foramen of Monroe to the third ventricle, and then we make a fenestration at the floor. What I use as a standard is a borehole exactly in front of the coronal suture. When you take navigation, it makes the ideal calculations. There are some papers that even show sometimes it's better you go behind the suture. But what is not good when you go 1 or 2 centimeters in front of the coronal suture, then usually you have to lift the fornix when you go to the third ventricle to reach the floor. So the best is, in my opinion, in general, when you have no navigation, just in front of the coronal suture, 2.5 centimeters from the midline. Here's one video showing our procedure. We make a small shaving, then sterile draping. We use an optical bridge, so we can change the endoscopes, ventriculoscopes during the procedure. That is very helpful because I always like to take a 30-degree endoscope to look down to the prepontine system to make sure that all membranes are open. What's not mandatory, you can also do just with a ventriculoscope, and then you don't need this optical bridge. White balance, then we puncture the ventricle with a cannula to get CSF for lab results and also to confirm that our trajectory is okay. So when your trajectory is not okay, you have not done it with a ventriculoscope, but you have done it with a small catheter. Here the endoscope is taken out, and then we take a diagnostic scope. We have 30-degree and 45-degree and 0-degree. We connect the new scope, and then we go in. You see here, this is a third ventricle, infundibular recess, memory bodies, and then we turn the endoscope just by turning the light cable. So the endoscope remains, so it's no tilting. Then we can look back, and you see here the entrance to the aqueduct, very close. You see here it's a fornix. Now we switch again to the other scope. It's a 45. It's a black signal here, and you see we just turn the light cable, and you see central gray is the head of the caudate nucleus. We look back, then we come to the aqueduct, thalamus striate vein. Thalamus, I'm sorry, this is the thalamus. Then you see coroplexus. It's a trigone. You see the septum, it's moving. Sometimes it's perforated because of atrophy from the chronic hydrocephalus. So the mutation is, of course, then here's the temporal horn. You cannot go to the temporal horn because you have a rigid endoscope. For this, you need a flexible scope. But this is what you can see with the 45-degree endoscope. Then we just rotate it backwards. Then can enter into the third ventricle. You see it's thalamus. This is a septal vein here, fornix here, coroplexus. And now we go with 45-degree. And you see here, this is the fornix on the contralateral side. This is a contralateral foramen of Monro. Lamina terminalis, this is the anterior commissure, goes from one fornix to the other fornix. And here you see A1 and a communicating artery. So again, it's a chiasm. Then we look back and you can see the entrance into the aqueduct, posterior commissure, aqueduct, pineal recess, habenular commissure is here, and the suprapineal recess, and then the roof of the third ventricle. So all this can be seen. So borehole, what we do is 1 centimeter. We have some flexibility to move it, and we tap the ventricle. What we always have is an optical trocar. Optical trocar means you have an opening here where you can put an endoscope in. And then you can see exactly where you go. So it is helpful when you have a small foramen of Monro, which is larger than the trocar. When you go in without this, it's a high risk to damage your fornix. Look here, this is a patient with a hamartoma. You see the very thick thalamus striate vein. So this is a fornix, and here's a plexus. And you see when I want to go with my sheath, it's too sharp. It will damage your fornix or the veins or both. So that's why we make a very limited foraminoplasty to dilate it a little bit. Then you have some space. And then we take the optical trocar. And this conical shape, this moves the fornix to the side. And you see here, this is a hamartoma. You can enter it and you see there's no damage. When we go out, there's no damage to the fornix. So the optical trocar is very nice when you want to go through a small foramen, which is a little bit smaller than the endoscope. Of course, when the difference is 2 or more millimeters, then you rupture the fornix, then you should not use it. The floor of the third ventricle looks very, very different. Sometimes it's like here, it's a good case, translucent floor. You see the basilar apex, mammillary bodies, and fundibular recess. Here's the clivus. So we make the opening just behind the clivus. Usually it's halfway between infundibular recess and mammillary bodies. Sometimes you have to adjust a little bit. It should be behind the clivus, then it's a good position. Sometimes you have this floor. You see here, it's translucent. Here's infundibular recess, mammillary bodies. Even if the space behind the artery is thinner than in front, you should never go posteriorly to the basilar apex because here are the perforators and it's a risk to damage them. You see here the oculomotor nerve is shining through the floor. And what is this? This is a small PCOM going from the carotid to the basilar. Sometimes you don't have a translucent floor. Then where we make the fenestration, you go in between halfway infundibular recess, mammillary bodies, so just here. Sometimes the floor is very thin and it's bulging down like an arachnoid cyst, covering all the basilar, goes down here. Where we make the opening here on the clivus or a little bit away, but never over the basilar artery. And like here, in this case, you see a very prominent PCOM. This is the fetal origin of the posterior cerebral artery. And then, of course, you have to adapt where's the best place to make the fenestration. Here's already the clivus, and you would make it like here. But never here. You see how big the perforators are They are usually covered by the mammillary bodies, but they are always there, and there's a high risk you damage them. So always go in front. We use the deck forceps. It's a blunt forceps. You perforate the floor, you dilate it a little bit, and then we take the Fogarty balloon catheter to enlarge it. You know, there's also available the double balloon catheter from, initially it was Codman, where you have two balloons, but they're very expensive. So what we use simple Fogarty catheter. Here again, you see some perforator running here, mammillary bodies, tuberous cinereum, infundibular recess, where we make the fenestration just behind the clivus. Then it's important to make an opening, should be around 4 millimeters in size. When it's too small, there is a risk that you have an occlusion. It should not be too wide. You should not damage the vessels which are running here. Depends from the width of the force of the floor of the third ventricle. Sometimes very wide, and you can make a hole of 5 or 6 millimeter even. Sometimes it's smaller, then you make a smaller opening. And it's very important that you not only open the floor, but also the Liliequist membrane. When the Liliequist membrane is not open, you have not this pulsatile flow, and the ETV will not work. What we want to see when we make the inspection with the 30-degree endoscope is this: basilar, subarachnoid space, perforators, no membranes around it. One example, young girl with progressive memory issues, headache, see large lateral ventricle, dilated third ventricle, bulging of the lamina terminalis, bulging of the floor, and here small tectoglioma. Again, you see tectoglioma, large ventricles. What we do, ETV, of course. You see white foramen, no danger to damage it. You see there's already the floor bulging up because we release the pressure in the ventricles. It's a good sign. Deck forceps. You open it. Then we take the Fogarty balloon. And now you have to play a little bit because the floor slips up, slips down. You have to just catch the floor at the circumference of the balloon. It's a little bit more difficult than with a double balloon catheter, but this is just 25 euros. The other one is over 100. So we save one. You see now Liliequist membrane below the horizontal layer of the Liliequist membrane should be dilated as well to get a wide communication. You see, when you see this pulsation of the floor, it's a very good sign that down is no other membranes. And you see here, it's confirmed subarachnoid space, good pulsations, and that's all what is needed. It's now over 10 years. I think more than 10 years, and she's still doing well. No need for a shunt. Sometimes you have, for control, we have this inversion recovery tubospin echo where you see the flow void very nicely. So sometimes we have an extraventricular CSF obstruction. You see there are a lot of membranes in front of the brainstem which interfere with the circulation. You see the aqueduct is open, but still there is bulging of the floor. So there's a sign that's the pressure differential between the ventricles in the cistern. And in these cases, we also make an ETV, although we have a flow in the aqueduct. Again, we go in. It's a little otoscope. We go into the foramen. You see the foramen is small. That's why I go with an endoscope into the sheath, so I have control over the edges. I go not completely down. I just want to see what is touching. Then we open it, the floor with the deck forceps. Then again, Fogarty balloon catheter. It's pre-filled with saline to have a constant, slow enlargement. When you have the air in, you have this pop-up phenomenon that suddenly the balloon is inflating. And you see below, you see already the membrane, the arachnoid membrane, like here, and this we open also with a balloon. And then we take our endoscopic sheath through the fenestration. We go in, and you see here's the clivus, and here's another membrane. So if there is enough space between the basilar artery and the clivus, we go in with the endoscopic sheath to open this membrane. And then I go deeper, and you see another membrane, exactly as we have seen on the cis image in the sagittal plane. And you see they are very thick arachnoid membranes. You cannot rupture them with a balloon. You have to cut with scissors. Make a big opening. And then we go down, and you see now we see the abducens nerve, and we can look down. There are not more membranes. So if you have these membranes and they are accessible, that means there's enough space between the basilar and the clivus. We always open this. And you see good flow void here. This is an interesting case we did 2 weeks ago. This is the first time we did this technique. You see aqueductal stenosis, dilation of the lateral ventricle, third ventricle, bulging of the floor. And you see here, there is a cavum in the septum pellucidum, cavum vergae. Here's the fornices. So we went in, and you see the very small foramen of Monroe. When I want to go with a little lotter, even the little lotter was not fitting well through it. So of course you could make a foraminoplasty and dilation, but in this case, we just went to the other side, and you see there is a lack of the talar choroidea of the roof of the third ventricle. Here's the other side of the ventricle. Here's one fornix. Here's the other fornix. And we could go in between because there's no talar, no roof of the third ventricle. It's open. So we come from above. We see the mammillary bodies, and we see the roof, the floor of the third ventricle. And here again, you see the perforators. It's a very thin here, but we never go behind because of the perforators. So we make the opening in front. This is a P1 segment of the basilar. And we go in with the deck forceps in front of the P1. And we open it carefully with the deck forceps. And then we come in with a balloon and make the opening. And here with the perforators, should never do this. And then you see the nice pulsation. When you see these pulsations, you know that the flow in front of the brainstem, it's okay. You see a flow void. So this is an interesting case because this is a young boy with 1.5 year old, had a big tumor, was treated with chemotherapy and tumor progression. And then the grandma sent the images of this boy. You see a big tumor. The whole hemisphere is tumor. This is a obstructed temporal horn on the right side. There was a ganglioma. And then when you look here, you see that all the brain is just pushed anteriorly. Now you see here the white spaces in between the gyri, but here it's very much compressed. And also here you see all the basal ganglia. It seems just to push. And that's why we thought it's an indication for surgery. And we made it a stage surgery. At first we put one half of the tumor, then we removed the other part. This was 2007. You see ventricles are good, not wide. And then 1 year later, he developed hydrocephalus. The question is why he developed hydrocephalus. He underwent ETV because he came from south of Germany and other departments 2 times, and it occluded again and occluded again. And then he came again to us. And you see, there's an aqueductal stenosis occurred because of the residual blood which was spilled during the surgery, I guess. You see, the ETV opening is occluded completely, although they did it 2 times. And then you see here, aqueduct occluded. This is the reason for the hydrocephalus. But why is the ETV stoma occluded again? So we open it again. Dilation with the Fogarty balloon catheter. Question why 2 times ETV was not successful. And then we see there's a lot of membranes. And all these membranes, they interfere with the pulsation, with the flow. That's why we went in and we cut all these membranes to get a free flow in front of the brainstem. You must be careful because there are some vessels, of course. Sometimes they are hidden. But now you see, I can look down to the abducens nerve, and when we go in with a diagnostic scope, you see everything here down is free. Just in the middle of the clivus, there were the adhesions, and probably because of blood spilling, reacted in this fibrosis of the arachnoid. And since this surgery, it's more than 12 years after the surgery, he did not require a revision. And this was 2008. It's more than 10 years later. Important is that we make the correct fenestration site. You see, this was also an ETV, which was occluded again. You see medullary bodies. Here was the opening. We look back. Aqueduct stenosis, aqueduct completely occluded. Then we make the opening. You will feel here now, this is the clivus. We are on the clivus and then we can go down. So it was a narrow space between clivus and the brainstem. So we open it with the Fogarty catheter. And then when we look in, you see this is the wrong space. We are in the subdural space, not in the subarachnoid space. And of course, this will not work. So we have to open the arachnoid to see the basilar artery. So we take a scissor here, open it, and now you see the membrane elevates. Then we make a wide fenestration. It's very important that you see that you have the subarachnoid space. When you are too close to the clivus, you are outside the tickle sac, and then of course it will not work. That is very important. What is with tumor-related hydrocephalus? When we have a tumor in the pinal region, we usually want to know what kind of histology is it, and we want to treat the hydrocephalus. So most of the time, we just take one borehole. The borehole ideal for the ETV is coronal suture. The borehole ideal for the pinal region is usually 4 to 5 centimeters in front of the coronal suture. So that means we go in between 2 centimeters in front, or 2.5. And then when the foramen has adequate size, we can tilt the endoscope to come from here to here. Of course, when the foramen is very small, we cannot do this. One example, see here, we put the borehole 2.5 centimeters in front of the coronal suture. We see the floor. It's not ideal. We have to elevate the fornix a little bit, but then we turn the endoscope and we can take a biopsy. This is always what we do with pinal region tumors, because sometimes it's germinoma and no surgery required. Sometimes we have a very narrow space between the basilar and the clivus. Is ETV then possible or not? And I think it should be possible, even if it's a very narrow space. You see again, the borehole is in the intermediate space, so I can reach here and I can reach also the tumor. So we go in, then we elevate the fornix a little bit. This is okay to get access here. And then you see this is already the clivus. And here comes the basilar. So the space is very narrow. But again, what I said, never go behind. You always go in front of the basilar. So we go close to the clivus. Here we had to use bipolar. Usually I don't use any energy sources, but here to open it, also the scissors, I open it. And you see there is some positive flow. Then we take the balloon catheter to open it, and we can make the inspection with a 30-degree endoscope, and you see it's open. So even if it's narrow, it should be done. What is about ETV in kids? It's very controversial. Some people say that age is a limiting factor. Some people say no, it's not a prognostic factor. Some people say that geology is it's a prognostic factor. Some say no. So when we have very young kids, even premature newborns, it's a very vulnerable brain tissue. CSF absorption is not very well developed, and etiology, in my opinion, is very important. You see, this is a child, 2007. You see, there's almost no brain parenchyma. Then you put the shunt in, and you see how much brain is expanding. So even if you see this initially, of course, you should treat it, because it's interesting how much brain tissue is re-expanding. This age a prognostic factor. This was a lady. He came from the south of Germany to us for birth, because they said this congenital hydrocephalus has to be treated with a shunt, and she wanted to avoid a shunt. And you see, this is after birth. You see here, redox stenosis, very wide ventricles. What we did, we made an ETV. Go in, you see, this was with the old fiberscope. You see the optic quality is not so good. So we make an ETV. You see the basilar here. And then we stopped. You see the ventricles became a little bit smaller. It's not much. You see the wide opening here. Good CSF flow. And you see this was the ETV. And then the ventricles came down, but they are still large. This is a difference when you make a shunt. Usually you have an over drainage. The ventricles come down more in size. When you make an ETV in these kids, the ventricles remain larger. Is this bad or not? 5 years after, you see, still open. She made a good development. No signs of active hydrocephalus. And when you compare it, 4 and 9, you see the ventricles came down a little bit in size. Not so much as a shunt. And then she came in 2017, and you see, after this long time, a good result, 13 years post-op. And there are some investigations here, a paper from Abhayat Kulkarni from Canada, and he said there was no association between the large ventricular size and the neurocognitive deficits. And you know, I think you know this prospective study, what we did in the IFNE, 5 years of outcome after ETV in aqueductal stenosis patients. And you see here, the ETV and shunt have the same outcome regarding the clinical result. But we have less complications with the ETV, so that we prefer to make an ETV instead of a shunt, also in the kids. But when you look to our series, when the patients are very young, below 6 months old, then we have a very high shunt rate, and the shunt dependence is not very good. But in older kids, when they are 1 year or older, we always try to make an ETV. When we have aqueduct stenosis and no infection, no hemorrhage before, we also try an ETV first, but the success rate is less. So for us, what is a contraindication? If they are younger than 6 months, ETV is not working well, especially in post-hemorrhagic hydrocephalus, it's not working well, and also with infection. When you make an ETV and you see this adhesions in front, then you know it will not work very well. And then we would not try an ETV. And this was a nice study on the double ANS in 2014, and they said endoscopic third ventriculostomy. There's insufficient evidence to recommend it in premature infants with post-hemorrhagic hydrocephalus. And I agree completely. The results are very disappointing, and we would not do this. What is about shunt failure? Shunt failure is always a good indication if it is an obstructive hydrocephalus. We have a success rate of 60%. When you have a communicating hydrocephalus, we have no success. So if you have a shunt infection, you see somewhere as an obstruction, then I think it's a good indication. One example, 40 years shunt dependent, came to us, see bulging of the floor. We make an ETV and immediately she starts to resorb and has a very good outcome. Okay, that was the evaluation of our hydrocephalus third ventriculostomy series. Overall success rate was 63%. That is because we also treated patients with obstructive, with communicating hydrocephalus, and this is of course brings the success rate down. If you have only adults with obstructive hydrocephalus, success rate in all this series was 75%, which is quite good. Should I stop or should we talk about complications?
Please continue. It's an excellent presentation.
Yeah, I don't want to bore you with too much details. What is about complications? Meta-analysis I did many years ago, mortality was 0.1%. But this is not completely true because most of the people do not dare to show their complications. And I know in Germany, and initially when we started with ventriculostomy in the early 90s, there were several fatal outcomes which were never shown in the literature. So that's why I think the bad outcomes are underreported because people don't publish their results. We published our complications in 2002, and we had the mortality from 0.5%. So 2 patients died. Why? Or first permanent morbidity, this was because a misplacement of the ETV. You see, it was too far lateral, makes the oculomotor palsy. It was too close to the infundibular recess, and we had diabetes insipidus. This is all which can be avoided when you place it in the right spot. And at that time, people use a flexible Fogarty catheter. So I always have the forceps, which is rigid, so it makes a hole where I want to have it. When you have the flexible catheter, it slides away, and then suddenly it goes lateral and makes a hole. And if you once make a wrong hole, it always goes to this hole. And that's why take a forceps and make it. We had one lethal SEA. When we published it, why did that happen? Because the surgeon made the borehole, made the fenestration of the floor behind the mammillary bodies. And then while inflating the balloon, one of small perforator was ruptured. And then it caused a subarachnoid hemorrhage. After irrigation, it stopped. But what happened? I think 10 hours later on the ICU, he had a severe rebled, and then he has this massive subarachnoid hemorrhage, and he died. So this was all technical errors which should not happen, which can be avoided. This would not be avoidable because it was a guy in very, very bad condition. He developed a wound infection, and then he had this multi-organ septic failure, and he died. But these other things are technical problems. Also here, you see here is an glioma. An ETV was done, and then a biopsy was taken, but this was not necessary because tectal gliomas, we don't need a biopsy. When we have the suspicion of a germ cell tumor, of course we take a biopsy. And simply by tilting the endoscope backwards, what happened is you see here a thrombosis in one of the internal cerebral veins, and you see here thalamic infarction. Just by tilting, it was a narrow foramen, the endoscope was tilted, and this caused here the thrombosis in the internal cerebral vein. When you see most of the complications are in the initial phase, all of these little complications in the first 2 years. In the last 2 years, in the last years, we don't have this severe complications. So there is a learning curve, of course. And that's why we report all honest complications to avoid it. We have always M&M conferences in our department that everybody knows what should be kept in mind. So what is the very important thing? The most important thing, in my opinion, is you should look at the MR images, not just see, okay, we make an ETV. Look, what is the size of the foramen? Is it better to come from the left? Is it better to come from the right? Is the pseudomostoid vein in the foramen? Is it outside? All these things have to be considered before. Where is the basilar? Is the basilar close to the clivus? Is it more to the brainstem? Is it left or more right? All these things have to be taken into account when you plan the approach. Then, of course, when you have a small foramen of 1 row, you should take a small endoscope. If you don't have a small endoscope, you cannot come with a 6 or 8 millimeter endoscope and go to a small foramen. You will destroy it. Always have a clear view. Irrigation is not always required because usually it's not bleeding much. But if you have some hemorrhage, then of course you irrigate, take a ringer solution. Don't take simple sodium, because then you can have this hyperventilation problem when you irrigate too much. Correct fenestration site should be selected according to the anatomy. If you don't see the anatomy, take the middle of the floor, halfway between infundibular recess and mammillary bodies, just in the midline. Look at the MRI to see, expect where's the basilar. And then blunt perforation of the floor. Usually we don't have any energy source. Sometimes if the floor is scarred, what I showed you in this one case, then of course we take bipolar coagulation, but usually it's not so important. So I think this is the most important message. Look at the images. So I came in, I looked here, I thought this is the clivus. And then I palpated and the clivus was moving. And then I looked to the MRI and see, oops, this is the basilar. So go in front, make the opening here, don't go here. Thank you for your attention. Any questions?
Yes. Thank you very much for this excellent and detailed presentation, Professor Schroeder. You can stop screen sharing. We can see each other widely. Thank you. It was a great opportunity to learn from a pioneering leader in endoscopic surgery. I got answers to almost all my questions during the presentation, but I just have a technical question regarding ventricular access in adults. Would the 6.3 millimeters sheet safely pass through the foramen magnum in an adult patient without increasing the risk of injury?
Yes. In adults, usually it's a large ventricle, a large foramen, and 3.6 is very narrow. It's very small.
Okay,
and
thank you.
If you, it's very rare that you have a foramen which is smaller. If you have, you can take the Fogarty balloon, make a little bit foraminoplasty, dilate it by 1 millimeter, and then you can go in. Or what I like is this optical trocar, because it's conical shaped and it dilates everything aside. It's not doing damage. When you take the endoscopic sheath, what I usually do, I go in the sheath and I see the outside, I see the margin of the sheath, and then I just go under the fornix and go in. If it is too narrow, so when it's too narrow, it can damage with the sharp edges, and this conical shaped trocar is better.
It's a good trick. And if a blunt perforator or back forceps is not available, would you consider using a Fogarty balloon catheter to perform the initial perforation?
This is what I said. This I don't like, because when it is not punctured, it slides to the side, left, right. Comes not exactly where you want. Of course, when you have this metal thing, a wire inside, and it's a bit more stiff, then it can be done. But I would prefer, when I don't have a deck forceps, I take a biopsy forceps.
Yes, biopsy forceps.
I close it, open it, or I take the bipolar diathermy rod without energy, just to take it for puncturing. What I don't like is what some people said, they go with an endoscope itself through the floor. This I don't like. I would never do this.
Okay, thank you. And Thank you. That was helpful. Now I would like to open the floor to our participants. We are truly honored to have so many distinguished colleagues with us today. I see several very experienced surgeons in the audience. And for example, I saw Professor Eylem Hocel from the USA. If you like to contribute to the discussion, please feel free to open your microphone.
Thank you so much, Selin. Good afternoon, good evening. And it is great to see you, Professor Schroeder, again. You know, I listened to your talks many times in US and everywhere, and especially in the IFNE as well. As always, it's a great talk. Thank you so much. And we always follow the techniques that Dr. Schroeder has already mentioned. I don't think we do anything differently. And as he mentioned, I think for me, there are a few indications, like patient selection is the most important thing. And even if it's like a great surgery, even if it's like Alice in Wonderland, it is still like, you know, to me, you know, I don't know, 100 feet under the sea, which is a dangerous area to look at if you do not know what you're looking at, or you don't have the enough experience. But for me, the most and the absolute indications, of course, as the professor mentioned, is hydrocephalus, obstructive hydrocephalus. In pediatrics, as a pediatric neurosurgeon, other indications, again, from Abaya's like abs, papers from the HCNRI, from Dr. Schroeder's group, is we know the post-infectious hydrocephalus or myelomeningocele, and other indications are still a relative indication, especially the ETV CPC, that we start using it since it's been more popularized in Uganda with Dr. Worf and his team, did not work as much maybe in the higher income settings. But for me, the absolute indication is obstructive hydrocephalus. I use it for other reasons as well. Patient selection is the most important thing. And even though it looks simple, if everything goes well, it's about just 30 minutes surgery. But if things go wrong, it really is very bad. So there are still a lot of complications that can occur with this in unexperienced hands. So I think it's a learning curve, and it requires a lot of patience. One other thing that I want to mention is the follow-up of the patients. As Professor mentioned, the ventricles do not come, and that makes all the neurosurgeons anxious, right? Why is the ventricles are not coming down? It's not like the shunt that you see all the ventricles. So as long as the patient is asymptomatic, as long as the patient is doing well, as Dr. Abaya's paper suggests, that there's no significant meaning of that big ventricles, even though there are some papers that says cognitive problems, learning issues, and all that stuff. But we follow the same techniques. It's not a simple procedure. I really enjoyed listening to our talk again. Thank you so much for giving me opportunity to talk.
Thank you
Thank you.
for your kind
Thank
words.
you.
Hopefully I'll see you in Buenos Aires this year.
Of course.
And a question from me about the choroid plexus cauterization you mentioned. It is useful in pediatric patients, I think. But do you prefer this in adults?
No.
No.
No, we don't.
Not ever. Okay. And
I think I have just one case. If you want, I can show you. This was an interesting case, but it's also rare.
Sure.
Can you see it?
Yes.
Yes.
This was a girl from Saudi Arabia, and she has a shunt, and she had a severe ascites. Severe ascites, and she came for shunt revision to us. And then we looked at the MRI, and you see the core plexus is very, very voluminous. So large. You see here, here. So what we did, we talked to the patients and said maybe this hydrocephalus related to an overproduction, which is rare. No? Usually we have it only in this papillomas. But here in this case, I thought maybe, and I made a bilateral core plexus coagulation. We have a flexible scope, but it is so thin So I said it's not effective. The electrode is not effective enough. And even if we use the big Lotta with a large electrode, it took one side took more than 1.5 hours to really coagulate everything. So I make the old borehole where you can go from here in the lateral ventricle and to the temporal horn, because the temporal horn is the most mess. You see here?
Yeah.
Big hypertrophic complexes. And then I came with my bipolar and the bipolar forceps, and we coagulated. It was so much time. With a flexible scope, I cannot imagine that this really will be effective, to be honest, because the electrode is so small. So we coagulated a long time until everything turned white. So one side was 1.5 hour coagulation. So 3 hours. And you see with the bipolar forceps, it was really effective. Coagulate. So the temporal horn all was coagulated, and then we went to the upper part of the lateral ventricle. And this is 2 days post-op. Ventricles completely down, and the ascites immediately disappeared because the resorption in the peritoneum is very much, you see?
Oh,
And since then, she did not require any surgery, so far as I know. Yeah, this was really an interesting case. So, but
thank you.
usually we don't make CPC as a standard.
Yes, thank you. It was an interesting case. And Professor Tuncer Turhan from Turkey, we would be happy to hear contributions from you. Tuncer Turhan. Yes.
Thank you for a good presentation, Dr. Schroeder. There's nothing more to say on this matter, but Dr. Schneider's presentation, we covered all of the problematic issues about the endoscopic third ventriculostomy. I wish to thank him, and I agree with the ALM. The indication is very important, and if indication is wrong, everything after the surgery will go wrong. Okay, this is the key point, I think. Thank you.
Yeah. Sometimes, you don't know exactly. The chance is a little bit low. It's not the complete, it's not like a tactic glioma, you have a very good chance. Then we talked to the relatives or to the patient and said, we can try. We don't know it's working. The chance is 60%, 50%. And even if it's 50-50, many people say, no, please try to avoid a shunt.
Yes, communication is very important,
yeah,
between the doctors and the parents. Okay.
Exactly. And then sometimes we try, although we know it's not the best chance, but sometimes it works and sometimes, of course, not working.
You're right. Thank you again.
Thank you, Professor Turhan. Professor Hakan Karabağlı from Turkey. We would be happy to hear your contributions too. Yes.
Thank you very much, Dr. Schroeder. Sorry about my voice. Very good lecture, very well. I have a few comments and questions. Questions first. Patients, child with obstructive hydrocephaly, not only obstructive hydrocephaly, and also pineal tumors. We always discuss which one is first, ETV or biopsy. Which one first? My question is about which one is the first performed during the operation.
Always ETV, because the patient is suffering from hydrocephalus. We want to treat his symptoms. We will always make an ETV. Sometimes when you make a biopsy, it starts to bleed. You don't see very well. It's better you make ETV first. This is done. And then you take the biopsy. Some people say, no, it's not good. We have to take first the biopsy because of spilling of the cells. But it makes no sense. If you take biopsies, then always there are some tumor cells circulating. It doesn't matter when you make the ETV before or after. So that's why ETV first always.
And also choroid plexus coagulation and ETV. Did you perform just choroid plexus coagulation or resection? After the coagulation, did you cut the choroid plexus and remove or
No,
not?
we don't. We do it very rarely. What I saw in this case here, we just coagulate. We don't resect the whole plexus, just coagulation.
Okay. Hydrocephaly patients, Charles, what are you doing for hydrocephaly patients? Did you
I don't see.
perform the choroid plexus coagulation?
I don't see these patients. We don't have.
You don't have.
Hydrocephalus. I don't. I cannot remember one case here from Greifswald.
Okay.
No. What we have is hydrocephalus aqueductal stenosis, and then we talk to the patient and we say, or to the parents, we try with the ETV,
Yes.
and you see it's working. Ventricles became wide, but clinically it's okay. But we have no hydrocephalus. So when, in Germany, when there's something wrong and people see this in the ultrasound, then abortion is usually chosen. So that's why we have severe things. It's very rare that we see this.
Did you use the ringer lactate or saline? Saline?
No saline. I did saline by mistake because the nurses were not from the neuro stuff, were from ENT, and they said we need irrigation, and we make irrigation in an arachnoid cyst patient. And then they want to extubate him, and he had a severe hyperventilation. They could not extubate him. They put him down, and then after 24 hours, the normal CSF was formed, and then next morning he could be extubated. So we always take Ringer's solution.
What are you thinking about the germinal matrix hemorrhage, premature patients, IVH, and hydrocephalus? Did you perform the irrigation
For which?
with the endoscope, neuroendoscope?
For what? For intraventricular hemorrhage in kids?
Hemorrhage, yes.
Yeah,
For
yeah.
infants, germinal matrix patients, we performed a lot of times, and we published. Irrigation is very important. Remove the hemorrhage and insert the EVD.
Yes.
What
You
are you
mean
thinking about that?
You mean endoscopic lavage? Yes,
Yeah.
we do. We always do it. We have not such good results in avoiding shunts later on, like Tomale has published in this paper, but it has an effect, of course. What we do, we clean it, and when required, we put a shunt when the patient has 2 kilograms and when the protein level is below 2 grams per liter. Then we put a shunt, but we make this lavage. Also, when we have infection, sometimes we had pyogenic hydrocephalus, ventriculitis, then also we irrigate. This is also very helpful.
Thank you very much for your lecture.
Thank you.
Thank you. Professor Eylem Öcal has contributions about this topic, I think.
No, I mean, I don't have much to say after, Dr. Hakan and Dr. Khan and Schroeder, but we see hydroencephaly patients in United States. It may not be as prevalent in Germany, but we still see them. And we don't do ETVs because for hydroencephaly patients, Abi, the indication is palliative, right? And then most of the time we see huge heads. The whole idea is to give comfort to the patient and the family to take care of them much easily and to prevent ulcers and everything. So I actually shunt them, and I call them palliative shunts, which is very common, of course, palliative shunts, because I don't think ETV included with ETV CPC works well for them with all that, head. It starts leaking. I think we see a lot of more complications. So I usually shunt those hydroencephaly patients, and I'm sure you might do the same thing. If it's a low resource setting where you cannot find the ETV and you still want to give comfort to the patient and bring the head down, you can certainly do ETV CPC like they're doing in Uganda and other places. So I don't use it. for lavage, Ulrich's paper, like Tamales paper, says that there's a, benefit to it. There are centers that does it in the United States. There's like mixed results, in my opinion. But in order to clean and then put the shunt in, sometimes it works better. And I used that before. It works in some patients, but I did not get a good result in many. So that's my humble experience.
Yeah,
Thank
Thank
you.
you.
I agree.
And Dr. Andriy Netlik from Ukraine.
Yeah,
If-
Andrei is one
has
of
those question connection?
Yeah, thank you. Thank you very much for the nice presentation. It's very important in practical sense, and I've gained a lot of information. I have one question about infectious diseases, infectious complications. You mentioned that you use lavage for patients with ventriculitis. So, in your opinion, if patient with ventriculitis has the hydrocephalic ventricles, could it be helpful to make ATV in this condition? I understand it's not the best way to treat, but in some circumstances we have no choice because shunt dysfunction is obvious, and we look for another option. What's your opinion?
So I think ETV will be closed. When there is still active ventriculitis, it will close soon. So what we had one girl where we make 22 surgeries because she always has some loculations. It was a multiloculated hydrocephalus everywhere, in front of the brainstem, behind, in the ventricles, everywhere. And then we open everything, irrigate. Then we have in the acute phase an external drain to bring all this infectious material out. And then when it's clean, we put a shunt. But she developed always somewhere a new localization, and we had to fenestrate it again, connect it with a shunt. And really, we had 22 surgeries. It is amazing. But now she's really good. She's going at the school for disabled kids, and she's enjoying life. So I think it's important to clean it. When they come initially, you know what is inside. All the stuff should go out. Then you start with your antibiotic treatment. You put the drains that everything comes out of it. But then we have to deal with all these loculations which frequently occur.
And how many times you repeat the lavage of ventricles in case of hemorrhage and in case of ventriculitis?
Yes.
What's the maximal quantity?
No, I think it depends from the patient. Usually after 2-3 times, it should be okay, and then you get the shunt. But if it starts to be a lot of protein or blood is still there, then of course we do it more frequently. It really depends from the situation. We want to have a clean CSF. So protein should be below 2 grams. When we make it more and we put a shunt, we have a lot of obstructions, especially because we use these programmable shunts. They are more vulnerable, obviously, than the standard valves. So we irrigate until we have the protein level what we want to have. And if it's very high, we do it also in front of the shunt. We just irrigate, everything goes out, and we put the shunt in.
Yeah, thank you very much, Professor, for your expertise. Our doctors from our department, as I know, were in your hospital, Dijak Yaroslav, he was the fellow in your department. So we use your skills in our everyday job. Thank you. And thank you, Hassan, for your contribution to education of neurosurgeons, and thank you to moderator for the nice moderation. Thank you very much.
Thank you. Professor Andriy Netlik is a very good friend of mine. He is from Ukraine, living in Lviv, and I want to thank him for his contributions. Thank you, Andriy.
Thank you.
Thanks for joining.
Thank you. And Dr. Emrah Egemen from Turkey, if you are here, we would be happy to hear from you.
I cannot see.
He's still in
Okay.
iftar.
Emrah Egemen.
Yeah, if he is here,
I think he has his connection now. He
okay.
has lost. And Dr. Sofiane Boli from Tunis. If you
Sophia,
would like to contribute,
uh,
contribution.
if you turn on your camera, you can come front, Sophia. I think.
She has a question in the chat part.
Sophia is a man. He.
Okay. Oh, sorry. Sorry.
Okay. I think he's left here, but
Okay.
you can read your
His question. Okay. Okay. Now I will direct the questions to you from the participants. First, from Dr. Sofiane Boli. In case of many shunting failure for hydrocephalus, there is an indication for ETV in pediatric patients.
When you have a shunt failure?
Is there?
Yes.
Yes, I
When
think.
there's a shunt failure, we look to the MRI. If I see there's an obstructive hydrocephalus, then we would do an ETV.
Yes.
When I see the communicating one, or we look in, sometimes you have a shunt failure, or you have a failure of ETV, you look in, the ETV is open, but the hydrocephalus is still there, then you know that the resorption is not okay, and then we put a shunt immediately. When we have an redo ETV, and we know from the first time there were a lot of membranes in the prepontine areas, and also we say we look inside, but probably a shunt is required. But if we have an occlusion and we make an opening and everything looks very good, then of course we make just a re-ETV.
Okay, thank you. Dr. Harash Parekh sent greetings from Mumbai, India. And Dr. Hasan Kamil Sucu wrote that super videos. Thank you for sharing. Professor Uygurer, dear Professor, thank you for your clear opinions and perfect video demos. Dr. Nilesh Moore has a question. In young infants and hydrocephalus with ETV, what's your experience of subdural collections in such kids? And how do you manage these issues? Thanks.
When you have subdural collections, we had mainly in patients when they have a very thin cortical mantle. And it depends from the clinic. So we had it also in adult patients, and he was asymptomatic from it. We just left it alone, and it resolved. Of course, when it comes more and more, then you have to put a shunt in to treat it. But in most of them, in most of our cases, it was self-limiting after a while. It did not become symptomatic.
And second question, how do you manage bleeding, hemostasis while performing ETV when the vision gets obscured and screen is all red colored? Any specific suggestions?
We make the so-called small chamber irrigation technique.
Yes, irrigation.
So we go in when it starts to bleed, we initiate irrigation. Then we go with the endoscope when we see closer to it with the endoscopic sheath, very close. And then we bring the endoscope into the sheath, 5 millimeters, and then we irrigate. In this small space, you can get clear. And then if you see the bleeding vessel, you can coagulate. But I must say, in ETV, this never happened. In ETV, you have just small bleedings from the margin of your fenestration site, and then you just irrigate, and after a while, it stops by itself. So when we have tumor resections, then sometimes it can bleed a lot. And then we make this small chamber irrigation technique. And when this is not working well, which sometimes can happen in severe hemorrhage, we make the dry field techniques. That means we take a catheter, we suck off all the CSF until the ventricle is empty. And then just because the air is there, it usually stops. And then we refill the ventricle and we continue with our procedure.
And do you use manual control of irrigation pressure or a continuous irrigation system?
Usually we irrigate only when it's required with a syringe. And then we have to you have to be very careful that the outflow is open. Don't it's obstructed. You irrigate too much, you can increase the pressure, and then you have a heart rate drop, bradycardia. So you have to be careful with this.
And question from Harash Parek: how do you seal tract of scope to prevent post-op CSF leak?
I never close the cortical puncture channel. I just put gel foam very densely packed in the borehole. In adult patients, okay. When you have pediatric patients, it's different. When we have pediatric patients, I make ETV, then I make only a straight incision and go in, and then I suture it and I put some Tachosil on it. But you know, when the resorption starts, then it should be okay. When it's not working, then you have a high pressure and you get the subgallia collection of CSF. That's always a sign that the ETV is not working well. What we do in some cases, we make repeated lumbar punctures to decrease the pressure, to give some time until the resorption starts. But this is only, it's not always successful. But if you have these, especially in young children, when you have the subgallia collections and you know ETV is not working well, and mostly you require a shunt later on. But with repeated lumbar punctures in adults, I would try.
Thank you. And second question from Dr. Parek: what are the flare rate of ETV, and what do you do after failed ETV?
What rate?
Failure rate.
Failure, yeah.
And what do you do after failure?
This I also have shown. The success rate is depending on the indication. When you have the ideal obstructive hydrocephalus, because aqueductal stenosis, we have a success rate of around 75%. In tectal gliomas, we have a success rate of 90%. So it depends. When you have a communicating hydrocephalus, we have a very bad outcome. Normal pressure hydrocephalus, we tried some, it's not working very well. So the failure rate always depends. If you have a truly obstructive hydrocephalus in adults, we have a success rate around 75%. And when it's, of course, what we do when it's not working, then usually a shunt is required.
Thank you, Professor. And a comment from the Professor Eylem Hocam: I still think every resident should know ETV success score chart. Yes.
Yes.
And from question and another comment from Professor Eylem Hocam: for post-infectious hydrocephalus results from Uganda for ETV plus CPC is good, but we could not replicate the same success in other places. The ETV plus CPC was done after the infection was cleared through.
Yeah. So I have not experienced much with this case. So we have not so many cases where we do this, and we have not much infectious hydrocephalus. It's very rare. It's really rare.
I think Professor Hakan Karavallı has a comment.
Yeah. Did you read the Nelson Atuzingo's
No, not yet. Okay, I can continue. Dr. Nelson Singuza, in settings of ventriculitis, after how long is it ideal to repeat the washout lavage?
In what case?
In the settings of ventriculitis, ventriculitis.
Ventriculitis that you do?
Yes. How long is it ideal to repeat lavage?
No, until the CSF is okay. When we start, we take CSF out, and then we make washing, and then we wait what is the lab, and then we continue to control it. And it depends from the findings in the CSF. So in bleeding, well, as I said, we want to have less than 2 gram protein before we put the shunt in. And when you have infection, of course, you don't want to have any active bacteria inside. So it depends always from the clinical situation and, of course, from the lab of the CSF specimen, what you take.
Thank you. And there is another question and answer after that. To Dr. Öcal, in cases of large head infants with hydrocephalus, which pressure shunt system you prefer? And Professor Öcal answered, I still use simple size systems. If you have programmable valve, it is better to use programmable and start with a higher settings to drain slowly to prevent structural hygromas. If not, I use simple Delta 2 valve. Start with slow drainage to prevent structural hygroma. And comments from Dr. Öcal.
But Celine, this is my humble experience because there's a lot of other systems that Professor Schroeder and our, Hakan Abi and all the others have used. So this is what works for me. But, there are more valves and more systems. So I use simple systems. And then to prevent CSF leak or subdural hygromas, I start with a higher setting if I have programmable. But programmable valves are expensive, not for everyone. I have the luxury of having programmable valves in many, many valves. But I start with like a, higher pressure system, simple. That's my humble experience. So I know there are a lot of other systems that you guys might be using, and especially in Germany, where all these headquarters of all those valve companies are. So,
yeah.
Thank you. Another question. What type of radiology, MRI, you get to see success of working stoma? Okay.
This is the inversion recovery tubuspin echo sequence. This is a flow sensitive T2 weighted sequence where you see a black signal.
Yes, sure.
Before we make the cine MR imaging with this cardiac gated thing, where you see the pulsations, but the clinical routine is not needed. And our radiologist is happy that he don't need to do it all the time because it takes too much time for him. But the inversion recovery is really nice. We compared it and we found this is really, for the clinical setting, it's really the best.
Thank you. And last question from me. It's a basic technical question.
Professor Hakan Karabaoğlu.
Okay.
Ladies first, Selim first. You can ask your question.
It's a basic question. During dilation with a Fogarty balloon catheter, what is the maximum safe volume, inflation volume to avoid injury around structures?
So that depends. You mean the size of the ventricular stoma? How much? How large it is?
Yes.
Or you mean the volume which I put
in
the...
adults, in adults patient, when we talk about adults patient.
Yeah, usually we put, the diameter should be around 4 millimeters. So it's an average. Sometimes maybe it's 3.5, sometimes it's 5 millimeters, it depends. But when you make it just 1 or 2 millimeters, then it's a little bit small, and then the risk is higher that you get an occlusion. And you must be careful. Sometimes the nurses give you the syringe, and it's more inside than the balloon can can take. We had it also, we inflate and suddenly poof, it was rupturing. That is a little bit scary because you never know what's happening to the basilar. So you should be careful and take not too much of volume. But I always take fluid, I never take air, because when you have this air, it's the same when you inflate the balloon, suddenly inflates large, always constant with saline, and then you can guide or you can control the dilation very much better than with air.
Thank you. And Professor Hakan Karavallı.
Okay. Dr. Schroeder, I have an interesting comment and question about the closing burr hole. My friend, he is from Germany. He's a neurosurgeon. In his institute, they usually use a bone wax, full filter bone wax. A few times I used, but one of them I saw an infection. Did you perform the bone wax in order to close the burr hole?
No, never.
Never.
Never bone wax. So we had one of our guys, he put the bone, what he drilled. Then he drilled it, collected the bone, put a little bit gel foam, and then he put the bone in to close it. After 2 weeks, we saw that the bone was in the third ventricle at the foramen, at the stoma, and occluding it. So please don't do this.
Okay, I
Don't
agree.
put it back.
Okay, thank you.
Sometimes when we make colloid cysts, and then we have an approach here, which is cosmetically not nice. Then I put a titanium plate to avoid the indentation of the borehole for cosmetic reasons. But I always close it with very dense packed gel foam, press it in so that there's a little bit, sorry. Yeah.
Okay, thank you.
It's like the cork in the butter.
Thank you, Professor Schroeder and all experienced participants. As far as I can see, there are no further questions and comments. Thanks again. I give the turn to Professor Sucu for the closing speech.
It was a wonderful night for me, indeed. I want to thank Professor Schroeder. I learned a lot, really a lot. It was amazing for me and for everyone, I think, who joined us. I want to thank also everyone who joined us this evening. Thank you so much. Thank you.